Thought Leaders, a closer look for the curious.
Good afternoon and welcome to Thought Leaders today. Today I'm going to be joined by Dr. Paul Hynds, and Paul is fountain of knowledge on lots of different aspects, but in particular Paul is working on some COVID data, and I'll let Paul introduce himself and he'll explain a lot more what he does and what he's doing at the moment. Good afternoon, Paul, and thank you so much for joining me today. I know you're very, very busy at the moment. Paul, do you just want to let the listeners know what you do, what your background is, and then we can get to the information about COVID.
Sure. So my name is Paul Hynds. I'm not quite sure what I am. At the moment, I'm primarily a mathematical epidemiologist based here in TU Dublin. Well, I'm in Inchicore at home, but I'm being paid by Technological University Dublin. I'm a PI there, so principal investigator in ESHI, which is the Environmental Sustainability and Health Institute. And I'm also adjunct professor in UCD, Queen's, Ontario, and McMaster, Ontario, in various different things, civil engineering and environmental studies primarily. My background is a strange one. I certainly didn't know what mathematical epidemiology was when I was 18 years of age. So like a lot of people, I did what I kind of liked to do or what I thought I wanted to do. And then over the years, I've kind of funneled from stats into maths, into biology, and then found epidemiology, and then found data and data science, and now I am supposedly a mathematical epidemiologist.
And for the listeners who don't know what epidemiology is, what is epidemiology?
Well, I suppose in a broad sense, if you want a definition, it's a study and examination of the patterns, spatial and temporal patterns of diseases or disorders. So a disorder could be anything. I typically look at infectious diseases, so bacteria, protozoa, and viruses, which is obviously why I'm now looking at COVID. I'm working on a paper at the moment looking at injuries. So you can look at essentially anything, and a lot of work, we're doing some work now into things like environmental psychology and risk perception. So you can also be looking at any disorder, any adverse health effect can be studied. It can be studied in terms of who it happens to, when it happens, where it happens, and then the kind of combinations of all of those things. So that's essentially what epi is.
No, that's fine. That you explained it very well, Paul. And you're looking at the data that's in existence and how potentially this impacts individuals' lives in the context of the data that's available. So in the context of COVID, because you gave a talk to me before and I was really fascinated by it, you started working on the COVID data quite some time ago. Am I right in saying that?
Yeah. I suppose when all of this happened in March 2020, or well, I suppose I would be kind of a little bit more clued in as soon as I see something about an infectious disease or an outbreak, epidemic. I'm obviously interested. So yeah, my head was turned, I suppose, January or December 2019. Things started looking fairly dodgy late January 2020, and then it was inevitable what happened in mid-March. So kind of, I suppose, February of 2020, I started putting some ideas together, started looking at the data that was coming from China and Wuhan specifically, started putting my ideas together, and then started putting kind of ideas for projects and project structure, etc., just to have it ready for March, April 2020. And yeah, we've been working on the data ever since, primarily the first 2 or 3 waves. Because it's very, very hard to kind of keep up with it. It's such a fast moving situation. So we're trying to essentially figure out the causes for and effects of those first 2 or 3 waves of COVID. And then a lot of EPIs and clinicians and doctors and biochemists, etc., are kind of working on the later stages of the pandemic, whereas we're focusing on the first stages.
You said you could see it coming. So from that kind of before the rest of the world started to stock up on various items, how could you see it coming?
Because the nature of COVID, or the nature of coronaviruses themselves, because of the type of infection it was, because the way it was transmitted, So obviously everyone will have heard of SARS and MERS, which are reasonably similar, not at the genetic level, but more at the species level, reasonably similar. And we have lots and lots. People don't realize we have lots of epidemics. We have ongoing epidemics almost all the time, but they tend to be quite specific and unique in how they're transmitted and who they're being transmitted between. Whereas we could see with COVID-19, it wasn't called COVID-19 at the time, that it was so easily transmitted. And because it's a respiratory virus, it was, and because of the nature of the world we now live in terms of travel, transport, etc., it was kind of inevitable that a major coronavirus outbreak like this one was going to become a kind of a localized epidemic, and then a national epidemic, and then a continental epidemic, and then once it hits 3 places at once, and it's monotonic, so everything is going up in 3 places at once. That's what your definition for a pandemic is. So did we know, or did I know that it was going to be of this scale? Absolutely not. But it was always going to become a pandemic. We kind of knew that probably February of 2020.
And do you think knowing kind of, and we could see it on the media reports, how I suppose the one that was the Sky News one that resonated with me, and them in Bergamo, you know, could we have reacted quicker as a global society, or was a global health just, there's all this data available, or could we have stopped it? I'm sure you might not be able to answer that, Paul, but anyway.
Personally, I don't think so. No, this was inevitable. In some way, it was inevitable with just the sheer volume of travel around the world. It was inevitable in a way. The nature of the virus itself, when you put all of these things together, it created almost the perfect storm. And then due to the sheer scale of it, do I think we could have stopped it? No. Do I think we could have done things differently at the start? Well, it's that, as my dad always says, it's easy to close the door after the horse is bolted, you know. No, to be honest, I wouldn't have any problem with most of what was done for that first wave, because who knew? You know, really no one.
None of us knew.
Yeah, and you have to kind of learn as you go. Now, I do think in the interim, in the last 18 months, 20 months, there are learnings there, and we know things now. And I think there are things that have happened in the last six to 10 months that could have been done quite differently. But in terms of the initial stages, I don't think there was anything that could have been done really very much.
Yeah, I think because it was the lack of uncertainty, we didn't know. I suppose, now that we have entered back into the restrictions of the nightclub shutting a little bit earlier and all of that, and I suppose as a member of society, it's that, you know, I think we were all hoping when the vaccine came that there would be this light at the end of the tunnel. I think the public sentiment is a little bit deflated, if I'm honest. It'll be a little bit. Where are we now? What's going to happen?
Well, I mean, you could have asked me that every day for the last 20 months, and I would give you the same answer. I really don't know. There's 2 or 3 or 4 kind of ongoing threads, or kind of parallel, I suppose, levels at which this is all occurring. I suppose there's a lot of talk 12, 18 months ago about, let's say, the flu pandemic 100 years ago. But it's apples and oranges. There's just no point in comparing the two because they're so inherently different. So one thing we have now, and I've had great chats about this, what we have now that they didn't have back then is obviously travel, free, easy, cheap travel. Another thing they didn't have is Facebook and Instagram. And I think that has a part to play in terms of risk management, risk communication, but it also has has had detrimental effects in terms of risk perception and misinformation and miscommunication. You know, I mean, this idea, I had this very interesting conversation with a friend of mine a month or 2 ago, where he said, up until all of this happened, I really believe that everyone in the world has the right to their own opinion, or everyone has a right to an opinion. And he said, I've fundamentally changed how I think. That, no, I don't really believe that everyone, you may have your own opinion with regard, let's say, to a vaccine. You don't have the right as a carpenter or as a plumber or as a shop assistant to start communicating that opinion across Facebook and Instagram and everything else. I understand that people are deflated with regard to the kind of the overarching efficacy of the vaccine. People thought, well, this is the silver bullet, etc., etc., etc. There is no such thing. If there were a silver bullet, we would have eradicated flu. And that's for 2 or 3 reasons. So the vaccine was never developed to kill COVID-19. That's not what vaccines are for. It was always meant to minimize or reduce the instance of really severe COVID. So ICU, death, hospitalization, etc., etc. Which, if you look at the stats, it's undoubtedly done. If you look at, in the last few days, we've had 4,000 to 5,000 cases of infection per day. And then if you look at, let's say, the hospitalization rate associated with those cases, and then you compare it to the equivalent, let's say, back in January of this year, it's absolutely apples and oranges. And that's primarily down to the vaccination. So that's kind of my thoughts on it. Anyone that asked me, I would say, don't be deflated. The vaccine is doing exactly what the vaccine was meant to do. Because if we didn't have the vaccine, at the moment, we would have hundreds of people going to hospital every day. The hospitals would be completely overrun, but they're not. I mean, they're under pressure, but they're not overrun. I don't know if that kind of...
No, actually, you gave me a little bit of reassurance, Paul. Thank you. Because it is, the vaccine was, and it has achieved what it said it would do, take the pressure off the health system. In the context of, is there anything in particular that you would say is contributing to the transmission of COVID that we could do better? I suppose. I think we're all now thinking about spending time with family and friends over Christmas. Is there anything we can do better to minimize the risk to ourselves and our communities?
Yeah, I don't know. It's a difficult one to answer. I mean, I can only answer for myself, really. So during the first 2 or 3 waves of COVID, my mum was quite sick back in 2018, 2019, and I was quite mindful of that. So I definitely minimized my contact there. And I know a lot of friends that did the same thing. If they have old or infirm or like recently or previously infirm friends or family members, they kind of minimize contact. Like, I certainly haven't been to a rave in the last 2 years, and I don't plan on going to one anytime soon. I suppose it's very much down to yourself and kind of like your own moral compass in terms of what we can do. I think people are frustrated with restrictions and everything else, and I think in the media, you know, there's a blame game being played, and I don't think that's fair, because we're an inherently social species. You know, we have to think as well that, like, every action has an opposite but equal reaction, essentially. So if you keep people imprisoned in their own bedrooms or on their own street for months and months and months and months and months, you can't expect that there's not going to be some kind of adverse effect to it. In terms of what I'm going to do going forward during Christmas, I'll do what I can do. In terms of, well, I won't be going to nightclubs because I won't be able to go to nightclubs. Will I go for a couple of pints? Yeah, but the restrictions that are in now don't allow me to go and meet 40 or 50 of my friends for those pints. So I'll probably go for 2 or 3 or 4 quiet ones and nip off home. And I suppose we've all become reasonably used to these restrictions. It's weird how abnormal so quickly becomes normal for people, you know. But in terms of, I wouldn't feel comfortable telling anyone else what they should do. I can only say what I would do, and I'll do what I'm allowed to do. You know, like I've traveled. I was in France for a few weeks not that long ago, but I'm double vaccinated, and I could legally get on. I drove, so I could get on the ferry, and I could show my vaccine pass, and I could get off the ferry, and I could show them my vaccine pass, and I could drive half the way across France on my own in the car. And get to my forest and do my thing in the forest. If I wanted to go for a coffee, I would have to show my vaccine pass because I'm in a forest, very rural area. I didn't need to do that very often. And that's it, really. like I don't know what to say to people about what can you do, what can you not do, because everything we're doing, all of these restrictions are inherently abnormal. So, it's a very difficult situation. And I honestly think that as a species, the human race has actually done just remarkably well, really, really well. If you told anyone back in late 2019 what's about to come, what's on its way for the next 2 years, they would say, no, humans can't do that. Our communities can't do that. Our countries can't do that. We have done it. I genuinely believe we've done amazingly well as a species.
I remember sitting watching Sky News one night. It probably was the April or May, and saying 90% of the world's population is indoors, and it's a statement that will always kind of almost take your breath away.
Yeah.
In the context of different pockets and outbreaks, which we've had different regions have specific outbreaks at different times, was there any particular reason that the data indicated that potentially would have happened? Now, it doesn't seem to be as obvious this time, because the vaccination obviously has made a difference. But certainly in the first and second waves, was there particular geographical regions were heavily hit? Was there any particular reasons that you could identify?
Yeah, I mean, that's what a lot of our work is kind of trying to tap into. Sometimes coming from a small country can be a disadvantage, but actually in my area, it can be an advantage, because you can study an entire country at once. Now, and you can study all of the various populations and subpopulations, et cetera, I suppose a really good example of it is, you mentioned it earlier on, is Bergamo. So North Italy. People are saying, well, why Northern Italy? And there are a lot of, once you explain it to people, you kind of go, oh, yeah, that makes total and utter sense. Why Bergamo? Why the north of Italy? Well, there's very, very strong trade routes between Wuhan in particular and northern Italy. In terms of if you look at what goes on in northern Italy, well, that's where the Italian fashion industry is based there. The vast majority of their materials come from the affected part of China. So there was a lot of travel of both materials and humans between those two areas. And then why did it really take off so much in Italy? It's that part of Italy has quite an aging population, but they also have two very, very simple things that we don't have so much in Ireland, for example. We don't have so much across Europe, particularly areas but we always look in epidemiology at the extremes. And so for COVID, we tended to look at Scandinavia on one hand, and the north of Italy on the other hand. So what you have a lot in the north of Italy and Italy in general is multi-generational households. So you have grandkids and kids and grandparents all living in the same house. We don't have it so much in Ireland. So there's a huge level of mixing. And then what you also have is, let's say in the north of Italy, again, across Italy, there are far more tactile subspecies than we are. They're constantly hugging, and it's that simple, that they're just in contact with people more than us as Irish people, and particularly, say, Scandinavians. They're just a more tactile sub-cohort within Europe. So when you walk into a room, the first thing you do is you get the how are you, the hug, etc., etc. That's transmission, that's exposure, it's person-to-person contact. Whereas if you look at, let's say, Sweden, for example, it took off far less quickly in Sweden for a couple of kind of the opposite reasons. For example, Sweden has one of the highest, I think the highest in Europe, level of a rate of people living on their own. It's a completely normal thing. Far more people in Sweden than across Europe live on their own. So there's just less daily contact with other people, and they're not as tactile. So epidemiology is actually extremely simple when you break it down. It's just we're trying to account for, okay, well, more or less people hug. And then we look at, okay, well, then do women or men hug more? Do you hug do children? Do you know what I mean? Like, you're just piling data on top of data. But where you look at any of those single data sets, they're actually really, really simple. It's where you start to pile them on top of each other. That's where the kind of all the machine learning and the mathematical modeling comes in.
Yeah, that was really interesting about Bergamo, because I actually hadn't thought of that for the fashion industry, and a lot of that imports will be coming in from, China, whatever. So, I knew the thing about the generational households, but not, and obviously the tactile culture as well. But so in the context of Ireland, say, for example, certain counties, got a lot of restrictions, a lot more than, say, my county here in Sligo. Was there any particular reasons that those counties had higher incidence rates from the data that you looked at?
Yeah, quite a few reasons. I mean, the first one is essentially the split. The first thing you can do with all health research in Ireland is you can split it into one of two categories, urban and rural. So we don't tend to have a lot of countries tend to have a rich versus poor inequity or inequality. We don't have it so much in Ireland because 90% of our population is middle class. It's, we're varying stratas of grey. We have we have a small proportion of very, very dark and a small proportion of very white in terms of income. But what we do have is rural and urban, and they're very different infrastructures. And so obviously in urban areas, I mean, you look at for quite a while, or a lot of the waves, we see everything in Dublin first, essentially, because you just simply have more people in Dublin. The more people you have, the more day-to-day exposures you have. And that's kind of that. Then there's an interesting, one area we've really picked out as being interesting, and none of what I'm saying is new. We all know it from the news. But our data analysis and all of our models always just jump on top of Cavan and Monaghan. And so we've run models to look at distance to the Northern Irish border, and it flashes up in every model. And it's got to do with, and so you can imagine how difficult it would be in continental Europe, but it's got to do with, so they're two different countries, and therefore the restrictions were different. So people were choosing, well, if the restrictions are slightly milder or less severe that side of the border, I'll go there shopping, or I'll go there for a coffee. And now they've switched. All of a sudden they're switching. So now I'll go there for a coffee, or I'll go there to do my shopping. So we're finding that a lot. Typically the far more rural areas, so places like Kerry, the county of Kerry, now at the moment actually Kerry, the incidence is quite high. But for the first two waves, it was just really, really, really low all of the time. And it's because if you look at the population density, essentially, more people, more disease for something like COVID-19. Because my group, we study a lot of, say, waterborne and foodborne infections. And they can be quite tricky and quite complex because they're based on all types of things like weather, soil, food types, all of this kind of stuff, because they have multiple transmission routes. Whereas COVID-19 has one transmission route. It's a person, that's it. So essentially more people, more infection.
Yeah, it's so simple when you say it like that, Paul. So it is. Do you think we've learned any lessons over the last number of months of how, as we progress and hopefully emerge from COVID-19, how to deal with pandemics?
I think from my perspective, we were extremely unprepared, and I'm not sure how much that has really improved over the last 18 months, but we were extremely unprepared from a data perspective. Like for us, running models is easy. Okay, the models may take hours or days or even weeks to run, but getting the data is really, really hard. Not so much hard, not difficult. Like it takes a long time because we don't have channels through which to get data really quickly. We have a paper that's in review at the moment, which looks at essentially, we call it a case of two paradigms. You can either go mathematical or statistical. Mathematical modeling, so a lot of listeners may have heard of the SEER models. That's still what we're using. So a new tranche of models came out earlier this week, which looks at best case scenario, worst case scenario, likely 1, likely 2, likely 3. We're still using those models, and that's fine in the absence of data. But we have so much data now. And we're actually, I don't know if people realize, we're not using those data in those models. Those models that are currently being run, they're essentially and exactly the same models as were being run 18 months ago. They're just tweaking the parameters. So all of a sudden, vaccination rates go up, et cetera, et cetera. they either tweak an existing parameter or they add a new one. They're not actually, there's no data put into those models. So I think that's something that we really, 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 really need to look at seriously. Is why are we collecting all of this data, but we're not using it? I think a lot of people, like in the general public, if they knew or read into the modeling, the approaches to modeling, and those models that are being used, and I have no problem with the modelers, the people doing the work itself, very, very brilliant, very intelligent people doing their best. But there's huge amounts, we have hundreds of thousands of infections now in Ireland, and therefore we have hundreds of thousands of records of infection. None of that data has been fed into the current models because those models are mathematical. They're not meant for data. They're distribution models. So it's, let's say this is between 1 and 3, and this is between 7 and 8, and this is between 25 and 30. We'll multiply those three things together. And that's your, and if you want a best case scenario for scenario 1, we'll say, well, that thing that could be between 1 and 3, let's pretend it's 1. For the worst case scenario, let's pretend it's 3. This is my problem with it. And I'm, like going back, I'm a mathematical statistician, supposedly. I have no problem with mathematics. I love it. But I think we should be moving away from that and using the actual data that we have in hand.
And is there any particular reason we're not using, moving away?
Presumably there is, but I don't know it.
Okay.
Because if I did, I wouldn't have helped write that paper. We put that paper up online as a preprint, and it got tens of thousands of people read it within the first week. Because it's what's being done everywhere. Because and I understand it to an extent. So with data, you can analyze data. So you have a piece of data in your hand or a data set, and I can tell you, well, within reason, we'll do inferential statistics or statistical modeling, and we'll kind of tell you, A, we think plus B leads to C. And if A goes up, C will therefore go up. Whereas, so you can't use, if you have actual data, you can't use it to model a hypothetical system. So we have data on, wave 1, wave 2, wave 3, wave 4. We can't really it's hard to use those data to figure out what is the best case and what is the worst case. For that, you need mathematical simulation. And I also know that, because, and it kind of comes back to my point at the top, is I forgive everyone, every politician and everyone at the start of all this, because it was just so unprecedented. There is no manual on how to deal with a COVID pandemic or any pandemic. So the best tool we had in our arsenal at the time, and it remains a strong tool, but the only one, I suppose, that we had in hand at the time was mathematical modeling. The SEIR model, so SEIR. So it's susceptible, exposed, infected, recovered. They're the 4 things that go into that model. They've had to find a way to put vaccination in, and et cetera, et cetera, et cetera. So it's a case of, well, we started with that one, so let's just keep going with that one. But now we have data. We have 20 months of COVID infection data. And as far as I know, and I could be wrong, but as far as I know, my group, we're the only ones that are looking at the data for whatever reason.
Okay. Paul, I could listen to you all day. I'm fascinated, but I'm conscious we're near the end of the session. I can't thank you enough for your insight and your wisdom. You've provided me with lots of things to think about, given me some hope that the vaccine is doing what it's supposed to be. But there is opportunities there with the data that's currently available by looking at it and addressing it in a different way. And I think that's something that we can all reflect on. Listen, Paul, thank you so much, and I hope to speak to you again soon. Take care.
Very welcome. Have a good one.
Thought Leaders, a closer look for the curious.